Okay, welcome everybody, or welcome back to the 6th annual Montreal Oscillometry Seminar, Part 2, coming to you live from the Zoom platform. Let's see, advancing. A quick reminder that we have some industry partners off-writing the cost of producing this and also supporting my research, so thank you. Stats coming out so far from last week's meeting, we had 137 attendees, although admittedly some must be repeats, so I'll go through and filter that properly and get you a more accurate figure next week. But certainly we had 18 countries who had signed in. The Respiratory Effectiveness Group, again, I want to thank for hosting the recordings on their website, on the Technologies Working Group. And in fact, last week's seminar is already posted for view at the link that's down below. So here's the program. We have a great lineup again today. Sadly, we have one of the presenters who is unexpectedly unable to be with us today, so we are going to have less pressure in terms of time. There will be only 5 talks, not 6. And we're still deciding whether we're going to add a 5th seminar on to compensate, or whether we can somehow squeeze our missing speaker into the series. So that will be probably decided in the next week. If we do add a 5th, it would be simply the week after, on 1 week from the last seminar. Also, it would be August 17th. So with that, I'm going to welcome to the podium Chung-Wei Chow from the University of Toronto. Chung-Wei has become a partner in oscillometry for a number of years, and is actually probably running one of the most productive physiology labs in terms of oscillation mechanics applied to clinical practice. So Chung-Wei, the podium is yours, and thank you very much for speaking to us. And following Chung-Wei will be Peter Sly, who needs no introduction to this crowd, coming to us from down under. So Peter, welcome, and thank you for participating in this year's seminar.
Well, thank you very much, Ron. And I also want to take this opportunity actually to not just to thank you, but to congratulate you on putting together this incredible symposium on an annual basis. You were kind enough to welcome my group, I think some 4 years ago. And in as much as I miss the in-person gatherings, I think during the course of the pandemic, you've really created this wonderful community of international physiologists, and the opportunity for many of us to meet people whom I think we only knew by name through their papers. And so this has always been a highlight for us in our group in terms of our summer, and putting it online means that we don't actually have to compete with each other to see who gets to go to Montreal. So thank you for that. So what I'm going to talk about today is really the application and some of our data using oscillometry in patients with pulmonary fibrosis. And let me see. Here are my disclosures, and more specifically, the thanks that I offer to my research group, because obviously none of this is possible without their intellectual input and their hard work in making sure that our studies are of utmost quality. So what I like to do today is really to give you an overview of our findings in patients with IPF, and what their oscillometry and what their lung mechanics look like, and show you some data and looking at the correlation between the structure and function as seen through oscillometry and CT imaging. And mostly I want to spend a fair amount of time with Peter to talk about future opportunities and thoughts about this study. Most of this work has been published, and this really has been a passion project of Joyce Wu, who does many things in my group and is highly skilled as a research technologist and a cardiopulmonary function technologist. So you may ask the question, why look at oscillometry and ILD? Most of the work that is published and a lot of the interest in oscillation mechanics has been in obstructive lung disease. Now, I'm a lung transplant respirologist, and and specifically looking at the ILD and the idiopathic pulmonary fibrosis, this has become the #1 reason for lung transplant around the world. And part of it has to do with the fact that the prognosis with IPF is just terrible. for patients who are diagnosed, at the time of their diagnosis, they're looking at a 5-year survival. And for us, when we see these patients as they're being referred for lung transplant, the question is, where are they in that trajectory along the Niagara River before they actually go after this? Because deterioration is rapid and it's unpredictable, and it can be terrible, particularly for patients who don't make it to transplant. And so really the question is, are there other methods where we can actually look at these patients as they are sort of early in their journey with pulmonary fibrosis, to be able to actually provide a sensitive metric in terms of what their disease severity is and what their prognosis are? And by corollary, what it means is that the current markers of disease severity are actually bad. And in fact, they're quite insensitive. A lot of this, in the current, within the field, the current prognostic factors are that of the FVC, diffusing capacity, and the 6-minute walk. And this concept of putting these things together through this gap score, which takes into context the FVC and the diffusing capacity, along with gender and age, has been used by the IOD community to look at disease severity. And I have to say that this is not truly a gap score, but really a SAP score, because it's biological sex and not gender that actually plays into this. So we began the study. This is at this point sort of several years after we began our studies with lung transplant patients. And I was really quite enamored with the information that we were getting in the lung transplant patients, and really felt this oscillometry had a role to play in terms of looking at lung mechanics in IOD patients. And we enrolled our patients from the IOD clinic at the Toronto General Hospital, and only enrolled patients who had a confirmed diagnosis, idiopathic pulmonary fibrosis, as defined by the ATS guidelines. And we published some of the early results from this work. This was essentially 90 patients. And as you can see, they were mostly men who were older. And our population, like actually most of the work that's been published in other cohorts in IPF, was that these were patients who had relatively mild disease. And what we found was that their spectral oscillometry was actually only remarkable for this rightward shift in terms of the reactance curve, with actually very similar resistance values compared with normal healthy controls. And this is really illustrated here, where you see that because of this rightward shift of the reactance curve, is that we see an increase in the AX values and the shifting of the frequency of resonance to the right, but in reality, whereas the resistance values were essentially within the normal range. The real money, however, really is in intra-breath measurements. And what we see here is this very characteristic. So the top here, are the intra-breath loops of IPF patients. And what you see here is that there's this very characteristic decrease in the reactants, and at end inspiration, there's a significant decrease in terms of the values in comparison with the beginning of inspiration. This is really characterized by this looping of the impedance flow curves. And what you see here is that this value here of the reactants at end inspiration of -7, it has been very characteristic of all the patients that we've seen. And more importantly, when you look at the spectrum of the reactants at inspiration, is that you see this very characteristically sort of shifting of the distribution of these IPF patients, and each one of these bars represent one IPF patient, and in comparison with the healthy subjects. And what would, as these reactants at inspiration sort of drops further, what this is associated with actually increasing disease severity. And this is really illustrated when we look at the differences between the EXI values across the gap scores. So with increasing gap categories, it's increasing disease severity. And as you can see here, the EXI also drops as the GAP score or as the disease severity worsens. And lastly, we also looked at, in this particular group of patients, we also looked at CT scans, and in the work that was done by Michael McInnes in our group, he used lung texture analysis to quantify the extent of disease severity. And what you can see here is that the EXI values is most highly correlated with the extent of IOD within the CT scan. And this value, this percent vascular volume, which seemed to have the highest correlation with the EXI values. And it turns out that the PVV is the one metric on CT imaging that is most highly correlated with IPF survival, and it actually is more highly correlated than GAP score. So I'd like to conclude here to sort of boldly state that I think that oscillometry has a role in the management and the follow-up of patients with pulmonary fibrosis, and that EXI, the reactants at end inspiration or at zero flow, is a very sensitive marker of disease severity and could potentially be useful in following patients as they progress or following response to treatment. And more importantly, I think this offers an opportunity for other groups and other folks who are interested in this area to collaborate and to follow up with this. Now, we have subsequently followed these patients over time. We've also increased our recruitment, and I will not steal the thunder of anyone else in my group, but I will point you to a poster that Joyce Wu will be presenting at the ERS, and I hope that you will stop by and discuss and talk with us. Thank you very much.
Well, Chung Wei, thank you very, very much for a wonderful talk. Respecting the time limits, which gives us probably 12 minutes for the discussion, and really establishing another link in this emerging literature where intra-breath oscillometry here has been demonstrated to link nicely with the patient-reported outcomes and very impressively with quantitative CAT scanning. So I think these are two important keys to understanding what's going on that your group has established. But I think Peter Sly will be able to put this into perspective even more clearly, and more importantly, maybe flesh out some of the details of intra-breath lung mechanics, at least at 10 hertz, that he and Zoltan Antosh have been championing through the InCircle CRC of the ERS, and really complements nicely the work the Milan group is doing down at 5 hertz with intra-breath. So Peter, if you can turn on your mic and share your screen, I'll turn the podium over to you to take the discussion from here. Thank you for joining us.
I don't need to share my screen. I can just talk to you from here. But Chung Wei, thank you very much for that. It's very, very interesting data. I'm a pediatrician, and restrictive lung disease is something we see very rarely, except for interstitial fibrosis in infants. But what struck me is the major difference between what you're showing and what we see in early lung disease, for example, with cystic fibrosis or children with wheeze. All of our action is at end expiration. And in the children, as they breathe in, their lungs normalize. Whereas in your adults with IPF, it seems that as they breathe in, their lung disease gets worse. So and I guess that fits with the restrictive disease. We've been looking more at end expiration as a marker, and more recently at the slope of the volume dependence of reactants. And I think in peripheral lung disease, the action's all in reactants, as resistance has got not much to do with it. And so we see similar things. But I wonder if you could expand a little bit more on why you think the reactants at end inspiration drop so much as people breathe in.
Yeah, I think it's, and I think what we see is really the manifestation of the differences between the two sort of physiologic patterns. And that was one of the reasons why when we initially began our studies, we were very, very strict in terms of only enrolling patients with IPF as opposed to, IPF combined with emphysema or other forms of interstitial lung disease. And this is purely speculation. But I think that, when you think about what happens to the intrathoracic pressure, and when you think about what happens to a very, very stiff lung that will not expand, is that as inspiration occurs, is that that lung becomes progressively stiffer. And that is responsible for the drop in the reactants and inspiration, and the fact that as the disease progresses, that value, that EXI value, drops even further, would seem to be correlate with that. And the correlation with the PPV is really interesting, because I don't think that we really have any good explanation for that, except that there's some speculation that the percent vascular volume increases with increased severity because of increase in terms of vasculature as a result of decreased severity, and perhaps of increased flow to the intrapulmonary vessels with increasing intrathoracic pressure with inspiration. So that's sort of my speculation, and I think that's why you see in that those loops is that it's a very, very almost a straight line that drops.
Yes. I'll come to you in a sec, Solly. What we think, particularly at the lower frequencies, that reactance is dominated by time constant inhomogeneity. And you've got very stiff lungs, and so if you have a stiff lung and you make it stiffer by breathing in, you're going to increase so you're going to have an impact on the time constant. Now, as a pediatrician, I'm not that familiar with adult IPF, but I suspect your disease is more homogeneous than what we see in pediatric disease. And so that may play a role as well. There's also a big signal in your flow, in your reactance versus flow. My engineering isn't good enough to really understand the flow dependence here, and I'm not sure how to interpret that. But have you thought about looking at the flow dependence side of it?
We have, and I think. Part of we're still doing ongoing analysis with a lot of these data, and what we now have is a group of patients with combined pulmonary fibrosis and emphysema, and those flow volume, those loops, those flow reactance loops look very different from what we see with the pure IPF patients, and I think that sort of perhaps gets to some of the issues in terms of the time dependence of ventilation, whereas ventilation in the pure IPF would tend to be fairly homogeneous. So, and that's sort of on the basis of some of the CT analysis that Michael McInnes has done for us.
Right. And
Solly probably has a good
I'm going to ask Solly to comment just now, but also on some data that he's published in COPD. And showing sort of the ability to predict flow limitation very early in the loops. But Zoli, would you like to give us your comments?
Yes, thank you. Actually, the main feature of IPF in terms of Montreal Oscillometry is very marked fall in reactance with the inspiratory volume, which is due to the stiff lung, and also the lack of any inhomogeneity, which would do the opposite or would cancel out what we would be thinking here. So the upper left-hand side mark of the expiratory and inspiratory reactance, which is basically a hysteresis-free single pathway. So stretching during inspiration and relaxing during expiration. And that creates a very characteristic clockwise looping in the reactance versus flow diagram. So that's what was very tempting, and it's pretty rare and very characteristic of IPF. The other thing which I would like to comment on, yes, it is still speculative, but I feel that there's a strong physiological link between the pulmonary vascular volume, which is increased in IPF, and this behavior in reactors, which is simply, the link is the very negative intrapleural pressure, or transpulmonary pressure, or interthoracic pressure rather, which keeps huge blood volume contingents in the chest. And at the same time, this negative value does two other things. One is the decrease in reactance with inspiration, and also the totally normal resistance values, because the retracting forces on the airway tree are strong. So I think there should be some very, very strong interactions between circulation and lung mechanics in this particular phenotype. Thank you.
Junwei, have you had the opportunity to follow patients with uncertain diagnoses of IPF, and as they become more severe to develop some diagnostic criteria?
Not yet. This is an ongoing study, and we have a huge IOD group, and so I think that that is something that we're doing a little bit with Ron with his IOD cohort, but I think that will be of interest to us. But I will have to admit, sort of within the last 3 years or last 2 years with the with COVID, our enrollment has dropped.
Yeah.
But I think, and one of the things that we have is we have very, very early data with some of these patients in terms of follow-up, but we're unfortunately not able to we've not been able to follow patients as frequently as we normally would be able to do. But I think that will be of interest. And what's actually kind of interesting is that our largest cohort, which are the patients post-lung transplant, that we have actually a fair amount of longitudinal data. But
there's a different
situation.
You've had someone cut their airway in half and sew it back together. That sort of makes a difference. But one of the other things, my understanding from the pediatric side of things, is that the tracking the severity of many of these adult lung diseases has been very poor. So there are very few measures that actually work well to track the changes in severity with COPD, and also I think IPF. Have you been able to look at even cross-sectionally at how these measures track with severity?
I think the probably the biggest data comes from the correlation that we see with the EXI with the GAP score. So the GAP score is made up of a combination of the FVC, the diffusing capacity, gender or sex. So men get a higher score, and as one gets older, you get a higher score. And what we see, so this is sort of the cross-sectional data that we have, and I'm just going to sort of go back and just share again this. So I think what we see here is this, as we see with so as the GAP score goes up, or with increasing severity, what we see is that the EXI value drops even further. And I think if you go back and sort of look at this graph, here, I think the folks who are actually, within this far left are the patients with, gap stage 3.
Okay.
And as we move across, that these become progressively, less severe, and then it sort of bleeds into a little bit the healthy subjects that we have, and then there's no one sort of beyond on the far right where with IPF in that group.
Yeah, these are very interesting data. Robbie, were you trying to make a comment?
So Peter, we're coming up to 7:25, or we are in fact at 7:25. So
Right.
in the interest of not impinging on time with others, I'd like to thank Shang Wei for presenting her data. And Peter, to you, please, thank you for having moderated. Again, Shang Wei, thank you. I went out on a limb in 2014, having just started with oscillation mechanics, and said that the ILDs of my practice had a spectral pattern of what I call the half clarinet normal resistance with mildly perturbed reactance. You've confirmed that very nicely, so I feel vindicated. That was at a time when I knew little less about oscillation mechanics than now. I'd yet to meet many of you out there who have helped me with these concepts. So thank you for that. It's now with great pleasure I'm going to turn the podium over to Ramon Ferre from the University of Barcelona, who's going to turn oscillometry upside down for us and give us some food to think about in terms of looking at impedance as admittance. And likewise, it's wonderful to welcome to the seminar Rafael Delica from the Milan group. Please, gentlemen, take over the podium, and we look forward to this talk.
Okay, can you see my presentation?
Perfectly.
Okay, so thank you very much, first of all, to invite me to be here. I'm very happy to participate again in this meeting. So I will present something which is really not new, is something old, but I would like to be a little bit provocative as we are among friends, and to see whether you think about this issue. So to start some obvious issues, so oscillometry is useful for assessing changes in the respiratory mechanics of any given patient. For instance, in bronchoprovocation, in bronchodilation tests, also for detecting expiratory flow limitation in COPD patients when changing posture and PEEP, or to assess day-to-day variability to predict future exacerbations. So therefore, any possible step for optimizing the technique to improve sensitivity and specificity should be welcome. Today, I'm presenting an issue that was raised many years ago to correct for the shunt effect of the stratothoracic upper airways when comparing oscillometry data within the same subject or patient. The idea is to assess changes in admittance instead of changes in impedance. The concept is based on the fact that as the stratothoracic upper airway impedance is in parallel with lung and chest respiratory impedance, changes in admittance are freed from the stratothoracic upper airway shunt. This concept has not been applied in recent years, but to my knowledge, there are no data excluding the sound hypothesis that assessing admittance changes within a patient is better than assessing changes in impedance in terms of sensitivity and specificity. And I will present a little bit the reasoning of this hypothesis. This is the conventional setting of measuring impedance, where we have the patient and we apply oscillatory pressure and volume oscillations, and then we compute impedance as the quotient between the pressure oscillation and the flow oscillation, and we compute impedance with the real part and the imaginary part, resistance and reactance. But obviously, it is possible, equally possible, to compute the reciprocal. So to compute admittance, which is the quotient between flow and pressure, just one is the reciprocal of the other. Accordingly, the admittance is also a magnitude, a complex magnitude that has two components, conductance and susceptance, the real and imaginary part. So admittance and impedance are just equivalent because they are measuring the same, and the same information is contained in R and X, that in the components of admittance. Let's put an example that this information is contained in both variables. Let's imagine an adult patient and a frequency of 5 Hertz, measuring all magnitudes in centimeters per water liter per second. And let's imagine 2 points, before and after bronchoprovocation, for instance, or exacerbation. Let's imagine that the baseline, the patient has 5 of resistance, -4 reactance, and then it changes, keeping the resistance value, but reducing the reactance by double, so from -4 to -8. Or another possibility would be that from this same baseline point, not only reactance is reduced, but also resistance increases. So these both situations are found in the literature. And in that case, you can see here that either remaining resistance constant, or either if both resistance and reactance change, in both cases, for instance, the conductance, the real part of admittance, changes in parallel with the changes of reactance, -4 to -8. So you can see that we have a twofold change in reactance and approximately twofold change in conductance, which means this is an example just to illustrate that any change in impedance is paralleled by the change in reactance. So the first question is obvious: why we are using impedance? We are using impedance first from scientific tradition, which is very important. Also because it involves the concept, the classical concept of airway resistance. And also because today we have a big amount of data in the literature in terms of impedance. What would be reasons to use admittance? Well, in fact, conceptually, it also includes the concept of airway conductance. And they are both variables, similar interpretation. In fact, in the same way that resistance is the component of pressure in phase with flow, conductance is the component of flow in phase with pressure. So physically, the interpretation is very close. But of course, these reasons are not enough in favor of using admittance in comparison with impedance in general. But the point that I want to raise is that when measuring intra-subject changes in respiratory mechanics, admittance is conceptually better than impedance. This is the conventional setting, and when we apply a pressure oscillation, the flow is divided. In one part is going into the trachea and the lungs and chest wall, but one part is devoted to produce oscillation of the extrathoracic upper airways. So the impedance we measure, Z measured impedance, EDM is for measured, is the quotient between pressure and flow, is the parallel association between the impedance of the respiratory system and the extrathoracic upper airways. So measured impedance is the combination of these values according to the law we know. In fact, then it means that the impedance that we measure is not exactly the impedance of the respiratory system of the patient. How important is this difference? Of course, it depends on the magnitude of the shunt of the extrathoracic upper airways. This is a classical study showing the resistance and the real part and the imaginary part of the extrathoracic upper airways, depending on whether the cheeks are supported or unsupported. You will see that, of course, in case that cheeks are supported, the impedance is higher, of course, and the reactance is lower. But even at a low frequency, such 5 Hertz, the resistance is around 10, and the reactance is around 40-50, minus 40-50. So it's not infinite. Then there's the clinical solution, the typical solution we apply, everybody applies, is to support the cheeks, either the same subject or the operator, the technician. But it is important that to be aware that this is not equivalent. So as it was shown by this study, there is a systematic difference both in the resistance and the reactance in the whole cycle, only the inspiration and only expiration. So when the cheeks are supported by the own subject, all the values are higher. And I think that this is something which is usually not considered, but we should take this into account. So subjecting the cheeks is not is not sufficient to have elimination of the extrathoracic upper airway shunt. What could be the way to avoid this artifact, if you like? Well, this was described many, many years ago by René Pelin, who designed the so-called head generator, consisting in applying the oscillations not directly to the mouth, but around the head and also through the mouth. This setting was shown to almost eliminate the upper airway shunt. So that's very good, but the problem is that for clinical applications, for routine applications, this solution is really not useful. So it cannot be applied in practice, in other words. But the results are important, the difference are important. And here I show an example illustrating it. This corresponds to an example of a test of airway hyperreactivity in children. You can see here the resistance with the head generator, the baseline, after bronchoprovocation, and then after relaxation with salbutamol, okay? Typical response. When you are comparing the same maneuver, what is obtained using the standard generator, you see this response. Of course, there is still an increase after bronchoprovocation, but you can see that the amplitude of the change has been considerably dampened by the effect of the extrathoracic upper airways, okay? So what is the solution, if you like, or the point I am suggesting now here? So when in the same situation, when we have the impedance of the respiratory system and of the extrathoracic upper airways in parallel, we can compute either measure the impedance or the reactance. When we measure the impedance, we have this effect that we have mentioned before, and we measure reactance as they are in parallel. The reactance of the parallel subsystems is the addition of admittances. So both impedance and reactance are biased, are affected by extrathoracic upper airway. So measuring admittance instead of impedance by per se does not solve the problem in general. But what happens when we are measuring a change in a given patient? For instance, in the case of bronchoprovocation, bronchodilation test, or looking at differences between inspiration and expiration. So when we compare the difference in impedance between 0.2 and 0.1, we see that the change measured in impedance does not coincide with the actual change in impedance of the respiratory system because we have these coefficients. So again, the difference, the change in impedance we measure is not exactly the change experienced by the lungs and chest of the patient. But when we work with admittance, we have here that you have the expression and these two values, assuming that are unchanged, and I think that is very reasonable to think that by the fact of applying a bronchodilator or bronchoconstriction, there is no change in the cheeks and extrathoracic upper airway change. In that case, then you can see that these two values, the admittance before and the admittance after the test or the difference, you can see that then the change in admittance is free from the upper airway shunt because coincides with the change of admittance in the respiratory system. So whereas the difference in impedance is affected by the extrathoracic upper airway shunts, the situation with admittance is quite different, is unbiased. This was tested indirectly 23 years ago using a population test, a real clinical test data of airway hyperreactivity in children using the head generator and the standard generator in the same bronchoprovocation test. You can see here the situation, the measurements. This is baseline. In baseline were almost no difference in resistance between the head generator and the standard generator, and was a clear difference in the reactance, in the imaginary part. And after challenge, you can see that the differences in resistance was more clear. And if we look at the difference...
Excuse me for a sec, Ramon. Joan, could you please mute your microphone? Your background noise is interfering with the presentation. Joan Kagwima, thanks. Okay, carry on, Ramon.
Okay.
Wrap it up in a couple of minutes so we have some time for discussion too, please, because we're coming up.
I'm finishing. So if we look just at the change of resistance before and after the test, we can see that the result obtained with the head generator, so freed from the upper airway shunt, was higher than the one from the standard generator. And interestingly, when the difference were computed in terms of admittance, we saw almost the same results, showing that even using the standard method, when computing changes in admittance, the effect of the extrathoracic airway shunt was limited. So this, I will go back. This, I will almost speak that we can carry out simulations looking at the potential effect of the extrathoracic upper airway shunt, but I will prefer and to discuss a little bit, saying that theoretical analysis and the few data available strongly suggest actively assessing oscillometric changes within a patient in terms of variations in admittance. This, of course, does not preclude maintaining the traditional and well-documented indices on impedance, but also, in addition, processing the admittance data. Such a procedure would not require additional work since admittance data are always available from resistance and reactance. In fact, testing how changes in admittance work could be retrospectively carried out by simply reprocessing the resistance and reactant data already available in past studies. So, finding a potential improvement, even if minor, in sensitivity and specificity would be useful for the clinical application of oscillometry. So this is my point. Try to check whether changes on admittance within a patient may improve sensitivity and specificity. Thank you very much.
Well, Ramon, thank you for a great talk. Just when we clinicians were beginning to think we understood what was going on with oscillation mechanics, you have challenged us yet again. And Rafaela, your challenge will be in the remaining 3 minutes is to put this in perspective so the mere mortals like myself can understand how we're going to use this, but it certainly looks interesting. And I will likely play with the concepts in my own practice. So Rafaela, please take over the podium.
Thank you very much, Ron. Thank you also for organizing this event. It's extremely nice and interesting. So I hope that next time it will be in person, so we will be so that there will be opportunity to meet. But this is an extremely nice and important event. So thank you, and thank you, Ramon, for rising up this concept. I remember that I read your paper in 1999 when I just started my PhD. I was so impressed on how it was possible just by expressing the same measurements in a different way to highlight and to change actually the kind of meaning and information that you can get out from it. So there will be, we will need data, in vivo data, to understand how this approach will be really effective in improving our sensitivity and specificity in detecting changes. And as you were suggesting, the nice part is that we can do these studies by analyzing already collected data. So it's something that we can encourage everybody that is owning a database on correlated response to apply this in your approach and see how it gives. My main question is related to the different way that the admittance and the impedance express the upper airway shunt. So as you showed us very clearly, when you have measure the admittance, you have a simple addition of the two contributions, the respiratory system and the upper airway. When we deal with the impedance, the final effect of the combination of the respiratory system and the upper airways is actually depending on the relative magnitude of the two components. So we see minor changes of the respiratory system if the upper airways is much greater than the impedance of the respiratory system. And then while when the impedance of the respiratory system is similar in terms of amplitude to the upper airways, we have this major effect that you were showing us with the data from the edge generator. So my main question is, the simulation data are clearly in favor of the admittance, but in the admittance, we are measuring, we are showing the contribution of the upper airways in their maximum amplitude possible outcome. They are just added on top of the measurements. The data that you show us, for example, on studies showing the different effect of different approaches to supporting cheeks suggests that the impedance of the upper airways may be very different just by changing the kind of support. So even if admittance is reducing the impact of this relative contribution between upper airways and the respiratory system, but with the admittance we are really measuring the full amplitude of these changes in the upper airways. So what do you think that at the end the advantage of the admittance can be? So how can we deal with the upper airways to be sure that the upper airway shunt will be not changing between measurements, because these changes will affect massively overall.
Well, of course, using admittance has no advantages when measuring the absolute value of the mechanical load. So the only advantage I suggest is that when measuring impedance within the same subject, assuming that the impedance of the extrathoracic upper airways doesn't change, may eliminate the shunt, and then the changes actually experienced by the respiratory system are not dampened by the effect of the upper airways. And in fact, I think that regardless of the simulation, the data of the study I showed on patients, children, comparing in the same bronchoprovocation maneuver, the measuring data from the conventional setting and the head generator shows that certainly some advantages should be. Another point, which is not clear because has not been discussed, is whether these advantages results in better specificity and sensitivity. This is what is unknown. But what I'm suggesting, kindly suggesting, is that people already having data on changes in resistance and reactance in studies of within a patient, just to look whether computing the changes in admittance could improve somehow the sensitivity of specificity, because in theory, this should happen.
Well, thank you very much,
Ramon
Ramon and Raffaele. We're going to wrap it up because we have to move on. But I am going to actually, on behalf of Ramon, ask all of us out there who have clinical data and follow patients as I do, look at your visit to visit, before and after changing therapy data, and feed back to Ramon if this in fact is useful. And maybe at next year's seminar, Ramon will have some presentations which will follow up and use some real world clinical data to confirm or refute your hypothesis. I think this is absolutely fascinating.
I hope
And
that
Raffaele,
I hope that not me, but someone present new data saying, yes, it's true, or saying, well, in fact, in real life, it doesn't work. So
well, that's the point of these seminars, so we can network, exchange ideas, and move the field forward. So indeed, I share your thought. Thank you, Raffaele. And now with from Mexico City, I'm going to have Laura Gochio take over the podium, and she's going to tell us about some reference equations that span the ages. And happily, Claude Farah from Sydney is going to be moderating. So the podium is yours, Laura, and welcome.
Oh, thank you very much. Can you hear me and you can see my presentation? Yes, thank you. Okay, well, my name is Laura Gochicoa, and I'm going to present this work along with Dr. Mario Vargas and David Martinez Briceño about this novel procedure for developing a single oscillometry reference equation for 3 to 93 years old subjects. But first of all, I want to tell you that according to Cambridge, my English is B2, so I want to communicate most of this information to you. So in the last decades, oscillometry has gained attraction due to the greater options of equipment that right now are more accurate and portable. And moreover, studies have been made in children and adults that have shown that this oscillometry complements other tests of respiratory mechanics for the diagnosis and monitoring of diseases such as asthma, COPD, interstitial lung diseases, among others. And in some cases, it has been considered even more sensitive to detect initial changes in chronic pulmonary diseases.
Camera. Oh.
So one of the limitations of oscillometry is the lack of validated reference values, especially in adults. The last consensus reports 7 oscillometry reference values, most of them in Caucasians, and only 1 using the iOS in 45 to 91 years old subjects. There are reference values in children using the iOS, and like other PFTs, there is not a single reference equation that have been constructed continuously from childhood to old ages in the same population. So we have know that age has a great impact on iOS variables, as we can see in this graph. And we can appreciate that there are obvious turning points or breakpoints that we can see in how the scatter plots are. So it is common to find reference equations, for example, to evaluate only children, which are usually use linear regressions. And in the same way, there are these kind of equations in adults. So if children and adults are evaluated separately, it is likely that both equations do not tie in boundary ages like we can see here. So a multiple linear regression cannot adjust properly these breakpoints. So a piecewise or segmented model could adjust these breakpoints because, for example, for a same subject, we can have 2 different reference values for that same subject. So the objectives of our work is to provide a single equation for each iOS parameter for healthy children and adults, and to compare the results obtained in an Hispanic population living at moderate altitude with those from other authors. So we retrospectively obtained data from 2 previous studies that include healthy children, 3 to 14 years old from the metropolitan area of Mexico City. And prospectively, we recruit healthy volunteers older than 14 years of age from this same area. Our method is that the oscillometry was performed using the Jaeger Master Screen iOS, which was daily calibrated for volume, and we also put the reference impedance and weekly for volume linearity. 3 iOS measurements, each lasting 30 seconds and 1 minute apart, were carried out with cheek supports and nose clip. The acceptability criteria was the lack of artifacts, and in that time, the coherence of less of 0.6 at 5 Hertz and less than 0.9 at 10 Hertz. And the reported value was the mean of 3 acceptable maneuvers with a repeatability less than 10% in R5. So the statistics analysis, the equation for iOS variables were adjusted for sex, age, the inverse of height and inverse of BMI. And we used the package segmented from the R software that was used to estimate the piecewise model with 2 breakpoints for age. And during this software, an interactive procedure was used to estimate the final breakpoints, and the Bayesian criterion information was the one that indicate to us or to select the best model. We also show some scatter plots for iOS variables versus age and height, including smooth predicted values in this equation. So these are our result. We have 830 subjects. These are the ages that we have for these individuals. And the segmented package estimate 2 breakpoints for age, and therefore a single model for each dependent variable, except, as you can see in the table, for R5 minus R20. The final breakpoints were different for each variables, as you can see in resistance and reactance, and the predicted values presented a good fit for age, sex, height, and BMI. These are the reference equations for resistance. As you can see, for example, here in R5, these are the ranges that these breakpoints that the program found. And these are the adjusted R square. And here we can see that it's included the sex, the age, the inverse of height, and the inverse of BMI. The same is for R20, R5 minus R20, and this index R5 minus R20 over R5. These are the scatter plots for resistance versus age, and you can see here the breakpoints for each resistance and for this other concept of R5 minus R20 and this index. These are the scatter plots against height that you can see is very nice how this is connected, the regression line. These are the scatter plots for resistance versus body mass index. And here we can find the reference equations for reactants, for area of reactants, and for FRES. And we have pretty good also adjusted RFAR for each of them. These are the scatter plots for the reactants with the breakpoints that we mentioned before, and for the area of reactants and FRES. And this is the scatter plots for reactants against height, that it's pretty much the same that we look in resistance. And this is against BMI. We also wanted to show you this scatter plots for R5 minus R20 and for this index versus age, since we have heard and we have read some authors that publish some cutoff points for children and adults, considering that if, for example, a subject has an R5 minus R20 more than 0.07 kilopascal per liter per second, we can think that this is high, and we can consider that something is going on in the small airway place. And in children, it has been considered 0.15. So as we can see in this figure, probably is not correct to put to make a cutoff point. Also for this index that reflects probably that how much of the resistance of the whole system is comes from the small airways. These are the comparisons of our data that are these gray and black lines that we can see here for resistance. Amongst other equations, you can see here some of the children equations, and here some of the adult equations. Here is according to height, and our observer data and our equation is just in the middle of them. This is the same that we can see for reactants, and according to the height. And here we can see also for area of reactants and for FRES. The same thing for against height. So in conclusion, this study gives a single reference equations for each iOS variable for healthy children and adults. All iOS variables were strongly associated with height, but also with age and BMI. There is an abrupt drop in resistance in the first years of life, and then a slightly positive slope through adulthood, and the inverse occurs with the reactants. It seems that the proposed cutoff points for R5 minus R20 in children and adults are not adequate, and it will be better to use an equation for their calculation, the same concept for the R5 minus R20 over R5. So these reference equations probably are applicable in other Latin American populations, but also with other ethnic background using the same technology. So I want to thank to all our team that made us make this project. Thank you very much.
Well, Laura, thank you very, very much. And over to you, Farah, to in the next 5 minutes or 6 minutes, put this in perspective. And maybe if there's members of the audience who have been involved in publishing some recent equation, either reviews or equations out there, maybe draw them into the conversation. So please unmute yourself, Claude, and take away the discussion.
Thanks, Laura, and thanks, Ron, for asking me to be involved in this. I think you've done a stellar job communicating your findings as a B2 to this international audience. I don't know where I would sit on that proficiency scale. And look, I have to say from the outset, I have no prowess in statistical methodology. But I can imagine there's always room to have more reference values, and there are people in the audience who have been obviously involved in recent publications on that. I was just wondering, looking through your data, obviously it's a big group in terms of, you know, FOT literature, but still in each of your age groups, you've got about 40 odd subjects, heavily swayed towards the pediatric population. And then once we get into the teenage years, you go in 10 age brackets. And I was just wondering if you think that's an adequate number to sort of, I know your coefficient ratios were pretty good, but do you think that that number is sufficient for you to be comfortable to make that regression line as accurate as possible, especially around the teenage years?
Oh, yes, well, perhaps that was one of the main problems that we had, those individuals in that ages. I don't know why, but it's very hard to get them. I think the same happens in other reference equations, like for spirometry, for example. Those are the same data, but we try to recruit a little bit more of these adolescents, or in those ages. So I think with these breakpoints that also are in those ages, probably what we need to do is to validate, the next step is to validate the equations, and most in those ages.
Yeah. So coming to the statistical analysis, I was just wondering, why did you go for height and BMI when BMI includes the height essentially, and whether the BMI was necessary, or whether weight alone or some other metric of weight could have given different information, do you think?
Yes, we tried also with weight instead of BMI, but we found that BMI didn't have a collinearity. We test that, and we didn't find that something happened with the height, but also that is a better variable than using the weight, and we think that the weight it's something that we need to introduce to these reference equations.
Yeah, no, it is interesting that you don't have the collinearity in that. So clearly BMI is telling you something significantly different from just the weight. I think we have a hands up from Larry.
Laura, hi, nice to see you, and thank you very much. I really enjoyed your presentation. When we look at the data from the Global Lung Initiative, and we look at FEV1, FVC ratio, during adolescence, you know, there's a fall during childhood, but during adolescence, there's a slight blip up as, I guess, lung volume catches up with airway size. And I'm just wondering if you honed in on just your adolescent population, which is where you're really seeing your cut point or inflection points. Can you see something that talks to, you know, volume versus airway or airway capacity?
Well, we didn't test that, but I think we can do that because yes, I remember that that comes in FEV1 over FEVC. So well, we can do that. Thank you, Dr. Larry.
Ron, if there's no other questions, can I just ask a maybe controversial question to this audience about the R520, and whichever way you want to call it, R5 minus 20, R5 220, that nebulous thing that seems to defy all rules. Is there a message in there? I wonder if anyone wants to sort of chime in. If we can't even find a reference value, and it always seems to not follow the rules of everything else, whether it's R5 or R20 or X10 or X5. Is it a composite metric that we have created and are placing too much importance on, and cannot sort of be sort of regressed down to a normal?
Well, it seems Chung Wei might have something to say on the topic. So take down your hand and turn on your mic.
I'm getting the message. Peter Slides maybe agreeing with me.
Actually, I had a different question, and I don't think I'm actually really qualified to answer the R5 to 19 or R5 to 20 sort of question, but I think so. I'm going to dodge this a little bit and actually refer back to, and I think Jason probably can answer that better than I can, but refer back to our previous talk, which is really the concept that the cheek support and taking into consideration the shunt really plays a significant role. And I think, and I was really fascinated by the fact that support that is provided by the patient doing the test and being provided by someone else provides different readings. Like that to me was a real eye opener. And I think that in terms of trying to understand and for us to actually interpret oscillometry, particularly these R5 to 19 values, will be really beholden on us doing the test to make sure that we do it properly and that we understand what we're, how the test is done. So I'm going to dodge that one, but I actually have a question and perhaps, so Laura, it's lovely to see you, and that was a really great talk. But this whole concept of introducing the BMI in the reference values and calling that normal healthy reference. And do we as a community really believe that, or do we think that actually obesity is associated with actually lung disease and airway disease, and should we not be introducing the concept of a normal value that is adjusted for the BMI? So,
well, probably there are two things that we are looking there. Is, for example, the same body mass index in a child or in an adult could be grown for a child because they are growing, right? So, and well, it's very embarrassing, but here in Mexico, almost 30% of population has overweight. In this data, we just have 17 individuals that has obesity. But we have around 20, I don't remember the exact number of how many of them had overweight, but we try to test with the obesity individuals and without of them, and we found the almost the same result. That's why we decide to leave the BMI in the. I know that statistically that is not good because obesity and overweight is a not healthy person, but we think that it gives us, well, we didn't find a difference if we include them.
It's a difficult one. It's always sort of aging and weight. What is it just part of the reference, or is it a condition on its own that you want to sort of separate from whatever normality is, I guess? And I'm not sure we're going to find an answer to that tonight. Ron, if there's still time, there's two hands up. I was hoping Zolly and Jason.
Yeah, take them both briefly, Jason, and briefly Zolly, because then we'll move on to the next talks. But I'd like you both to have your say. So go ahead, Jason.
Well, I'll be very brief. I was just going to agree with Chung Wei that I think this R5 minus R20, I think the central airway shunting's got a lot to do with that. We haven't figured it out. And in that sense, it's not, if that, to the extent that that's true, it's not a reflection of physiology that we're interested in. It's a sort of methodological thing. So I'll just put it there. I'll hand over to Zoe.
Thank you. First, congratulations, Laura. It's a very nice and challenging approach, and makes us think for a while, I think. I completely agree on the comment by Chang Wei and Jason, and I'm very sorry to say that R5 minus R20 is a very ill-based measure, because just what Ramon showed us in the previous talk, for which I am very thankful, because that was a very, very nice tribute to our late friend and mentor, René Palan, and the work done in Nancy in this respect. So data he showed us were very convincing that these changes disappear when you eliminate the upper airway shunt. So if we are left with an ill-based measure like R5 minus R20, probably it is still better to normalize it by R5. So I would probably support Laura's conclusion. Thank you.
Okay, well, look, thank you everyone for participating in the conversation. Claude for moderating, Laura, great talk. It's now with great pleasure that I'm going to turn the podium over to Paulo Iglesias. Paulo is a second-year undergraduate at McGill, who's in his second year of doing oscillation research during the summer with me. I'm very proud to see his progress from entering spectral data and PFTs into an Excel spreadsheet last year to this year doing intra-breath analysis, statistical analysis, and graphing his results with Python. So Paulo, please share your screen, unmute your microphone, introduce yourself, and the podium is yours.
Okay, so thank you very much. Hey everyone. Like Dr. Dandrian mentioned, I am an undergraduate student studying rehabilitation science at McGill University. This is actually my second summer working with Dr. Dandrian. And so before I start, I'd like to express my gratitude towards him for providing me with this amazing opportunity to present the results of the study I've been involved in over the summer. So today I'd like to introduce the results of the study in which we looked at the strength of the correlation between COPD symptoms and intra-breath respiratory oscillometry. To assess this correlation, we first compared it to spirometry, but I don't think today's audience needs any introduction to this lung function test. We also compared it to spectral oscillometry, but likewise, I don't believe an introduction to conventional oscillometry is necessary today. Thank you, Dr. Chungwei Chow, for clearly introducing intra-breath oscillometry in your presentation earlier today. But I'll still give a small brief description of the parameters we decided to include in our data analysis. So intra-breath oscillometry only uses one frequency to assess lung mechanics as opposed to a spectrum of frequencies. Combined with an increased temporal resolution, this allows for the mapping of respiratory mechanics against volume, which is illustrated by the impedance loops on the right. As described by the labels on the graphs, the top left loop is data from a healthy patient, top right is an interstitial lung disease patient, bottom left is an asthma patient, and bottom right is a COPD patient. All of these loops and patients are actually from another study looking at oscillometric intra-breath changes, not from data in our study. So the resistance parameters that we looked at in the study were the end expiratory and end inspiratory resistances. To better visualize them, if the arrows on the COPD graph are followed, the end expiratory and inspiratory reactances are represented by the two black dots on the graph. So at the end of the inspiration arrow, so on the right, would be the end inspiratory reactance, and at the end point of the expiration half loop would be the end expiratory reactance. The same principle is followed by resistance parameters, where the red lines depict inspiration and the blue lines expiration, and their endpoints, represented by the black dots, represent these same parameters. The next parameter of interest would be the difference between both the end inspiratory and expiratory resistances, which is illustrated in the healthy graph by delta R as the difference in the y-axis of the two black dots. As I previously alluded to, reactance parameters were similar to resistance parameters and somewhat analogous. So there also was an end inspiratory and expiratory reactances and the delta of these end values. We also looked at one additional reactance parameter, the area of the reactance loop. So again, if we go to that bottom right COPD graph, this parameter would be illustrated by the area within the loop formed by both the expiratory and inspiratory reactance limbs on the bottom half of the graph. Some research has already been conducted looking at this novel approach to oscillometric analyses. So some have demonstrated that intra-breath oscillometry correlates better with patient-reported outcomes than both whole breath or spirometry in adult asthmatics, that it can predict future respiratory events in healthy infants, and it can distinguish between children and adolescents born either preterm or at term, and can predict the need for surfactant therapy in premature infants. We hypothesized that both whole breath, so spectral, and intra-breath oscillometry would correlate with symptoms as measured by the COPD assessment test and the Modified Medical Research Council dyspnea scale just as strongly as spirometry. So we identified 164 patients with complete spirometry, oscillometry, and patient-reported outcomes done from Dr. Danduran's community practice. Then patients were split into 3 groups: COPDs, who were classified following GOLD guidelines, pre-COPDs, who, unlike COPD subjects, had high FEV1 over FVC ratios and low % predicted MMEFs, and finally healthies, who were determined disease-free after a clinical, physiological, and imaging evaluation. Spirometry was performed at a hospital pulmonary function lab while respecting ATS criteria, and oscillometry was performed during well office visits using the Thoracis Tremoflow C100 oscillometer. For spectral analysis, patients underwent 3 to 5 20-second measurements over a 5 or 37 hertz oscillation spectrum, respecting ERS standards. And for intra-breath analysis, subjects underwent a 30 to 45-second measurement at 10 hertz, which did yield 10 hertz parameters. After an initial analysis, both patients with low reproducibility, so that was with a 5 hertz resistance coefficient of variation above 10%, and patients with extreme outlying data were rejected. So our final sample size was of 158 subjects, after 3 were rejected for low reproducibility and 3 more for extreme outliers. So on this slide, we see the results for biometrics and both patient-reported outcomes, the CAT and the MMRC. From our final 158 subject sample size, there were 23 healthy patients, 31 pre-COPD patients, and 104 COPD patients. Variables here are described by their median and their first and third quartiles, since much of the data followed a non-normal distribution. On the far right are the p-values for tests used to determine between group differences, so either the Kruskal-Wallis for continuous and ordinal variables, or the chi-square test for categorical variables. Then post hoc done tests were used to determine specific group differences. Here are the box form plots of 2 of the variables in the previous slide, split into the 3 study groups. So healthies, pre-COPDs, and COPDs. Age on the left did significantly differ, whereas BMI on the right did not, which is somewhat visible by the distribution of data plotted by these graphs. So healthy patients are visibly tended to be a little younger than both COPD and pre-COPD subjects. And in contrast, BMI distributions were much more similar between the groups. Here are the spirometric parameters, which by definition were all found to differ between groups since they were used as a group defining criteria. The general trend was that healthy patient parameters were significantly different from both COPD and pre-COPD groups, but the latter two did not differ from each other. The FEV1% predicted box-form plot included in this slide highlights the differences in disease severity between groups. And then the FEV1 over FVC ratio plot directly to its right reflects the use of this parameter as a classification criterion for the study groups. So that split at 70% is very visible between pre-COPD and COPD groups. Spectral oscillometry follows a very similar pattern where Kruskal-Wallis tests yielded significant results for all parameters. And generally, the differences were between the healthy group and both the COPD and pre-COPD groups. Again, both of these box-form graph, the left one plotting the R5 minus R20 and the AX on the right highlight this same trend as seen by healthy subject data points being condensed closer together than the other two groups. Finally, intra-breath parameters also followed the same trend where healthy patients differed from the other groups. So on the left plot, and inspiratory reactance is plotted, split into the 3 study groups. Then to the right is the reactance volume loop area, plotted, again split into the same 2 groups. And in both plots, healthies are clustered much closer together as seen in the plots from previous slides. So to measure correlations between parameters, Bonferroni corrected Spearman's correlation coefficients were used. So in this slide, all parameters from all lung function tests are included in the heat map generated from our data analysis. So this is very hard to see. So we'll split the heat maps into the different lung function tests and hone in on the strongest of correlations. So here's everything is much more visible. And we can see that each query contains 2 numbers, the top one being Spearman's row coefficient, and the bottom one, the p-value for said Spearman's row. First up is spirometry, where we identified 2 standout parameters, the FEV1 and the MMEF, which both moderately correlated to both the CAT and the MMRC, although the MMEF correlation was slightly stronger. Then the standout parameter from spectral oscillometry was the AX, which also moderately correlated to patient-reported outcomes, but was slightly weaker than spirometry. However, the strongest correlating parameter came from intra-breath oscillometry, the end inspiratory reactance, which had a Spearman's row of negative 0.55 with the MMRC, which was another moderate correlation, but the highest magnitude correlation of all parameters. Also, this heat map shows the particularly low strength correlations of the resistance parameters. These contain the only non-significant Spearman's row p-value with the delta parameter, which is visible by its very low correlation coefficient, even compared to the other resistance parameters. So here are all of the strongest correlating parameters from each lung function test put into one single heat map, which illustrate that the end inspiratory reactance did have the highest magnitude correlation with the MMRC, relative even to the other strong parameters. From all these results, we concluded that spirometry, spectral oscillometry, and intra-breath oscillometry were all shown to moderately correlate with patient symptoms as measured by the COPD assessment test and the MMRC dyspnea scale. Interestingly, the novel intra-breath parameters and inspiratory reactance had the strongest correlation with the MMRC. So it may be that both spectral and intra-breath oscillometry could be viable alternatives to spirometry for the assessment of COPD patients. So before I finish, I'd like to acknowledge and express my gratitude towards all the people on the slide who have made this study possible. So thank you, Dr. Dandrian and Dr. Hantosh, for your mentorship and innovative oscillometry work. Thank you, Carol Article, for acquiring the vast majority of the lung function data using this analysis, and Hugo Morin for consolidating much of the pulmonary function data. Finally, I'd like to give a huge shout out to Boehringer Ingelheim for providing the needed funds for the study, and Thoracis for providing the equipment needed for data acquisition. And yeah, that's pretty much it. If you have any questions, I'll do my best to try to answer them.
Okay, Paolo, thank you very much. I'd like the audience to know that this is Paolo's first scientific presentation, so very well done. And Yannick Basse from Laval, downriver from us in Quebec City.
Yeah.
I hope you're out there to take over the podium. Welcome to the seminar, Yannick. Good to see you. And we look forward to your comments and leading off the discussion on this topic that I think, Paolo, by the way, you gave a very clear introduction to intra-breath mechanics for those of us who are not familiar with it. So thanks for spending time on that slide. Yannick, the podium's yours.
Thank you, Ron. Thanks for the invitation as well. Yeah, it was indeed a great presentation, Paolo. Congrats. A lot of results too. When I look at those heat maps, it looks like I'm like genetic data when you look at all those correlations between all of the genes. Oscillometry is evolving. We can tell with your data. I'm not doing a lot of work in humans. I use oscillometry mainly to in animal model to study lung mechanics in different animal models. And we don't do intra-breath analysis in animals. We actually stop them from breathing when we apply the oscillometry, and this improve precision by quite a bit. But I can understand, and you can look at this variability within one breath to look if they can be predictive to symptoms or other outcomes. One technical question first, because I'm not a clinician. What exactly is CAT and MRC? Like what exactly you're measuring with those tests?
Okay, so the CAT is a COPD assessment test. It measures essentially the impact of COPD on a person's life. So if I remember correctly, I think it's an 8-prompt questionnaire. So each prompt can be ranked and answered from 0 to 5. And the lower the N score, the less of an impact COPD has on your life. And the higher the score, the larger the impact. So some of the prompts, so one, for example, measures cough, severity, phlegm, or breathlessness, and activity limitations. Then the MMRC dyspnea scale, it's essentially a scale that goes from 0 to 4, which measures the dyspnea levels experienced by patients when they experience breathlessness. So a level 0 would be during strenuous exercise. But someone who would answer 4 would experience breathlessness so severe that, for example, you can't leave the house or even doing simple tasks, so like when dressing.
Okay, thank you. That helps a lot, because you look at all those correlations between those index, and I wasn't really sure what you were measuring. Now, in terms of one of the highlight metric here, one more time, is the reactance at the end of inspirations, and we talked about that earlier with Dr. Chow, and here you're studying a completely different disease, but it's still the metrics that seems to best correlate with your outcomes. Like, do you have any idea what is your take on what this means, and when you have like a reactance at the end of inspirations that is very, very negative? What do you think it means, like physiologically, and how come it correlates with COPD as it was for IPF?
I don't think I have the physiological nor the engineering knowledge to answer this question correctly. But I'd like to throw it back at the audience. So I'm sure someone has some good input to give on this.
Yeah, the question is open to anyone in the audience, and I can see that Dr. Chow has his hand raised. Dr. Chow.
Thanks, Unique. And it's kind of interesting because I got into oscillation mechanics because I started the first part of my career doing lung function measurements in mice. So and I want to actually just take that concept further. So first of all, Paulo, that was a terrific talk. So thank you very much for that. And it was really clear. And I guess the question is, and I was really fascinated to see that it was the EXI in the COPD patients that really correlated really highly with symptoms. And so the question is, these are measurements that are made when there's zero flow and made at a time when the lung, or in inspiration, when the lung is most fully stretched. And so the concept is, do you think that we should be actually looking at lung mechanics and looking at lung function that we're actually more sensitively evaluating the actual properties of the lung when there is no flow? And should we be sort of looking at that much more in terms of the correlation with symptoms or disease severity? And I don't have the answer to that. And this is sort of a question that I like to sort of throw out there for further discussion. But I also, before I sort of turn this on to someone else, the other thing that I found really fascinating in your slide, and maybe Paulo, you can sort of go back to your loops, was the very clear difference between your asthma and COPD patients in this loop. Particularly in the reactance loops. And so do you think that this might actually help us in terms of differentiating the difference between asthma and COPD phenotypes? Because I was very struck by the differences in that reactant and those reactance loops. So I'm gonna lower my hand at this point and ask for input from others.
That's a great point, Chung-Wao. I know Paulo has looked at several hundred. It's hard to know bias. I don't know, Paulo, do you want to comment? Have you been able to see patterns? We're going to be looking at that in more detail and systematically, but do you want to give an answer just off the cuff based on all the loops that you've been looking, which are many hundred at this point in time? Do you have a sense? Or are we good enough in our anonymous labeling that you can't figure out who's who as you're doing the loops?
Just from memory, I haven't really identified a pattern. But there certainly are marked differences between patients as I go through analyses and I change patients. So if I were to have access to diagnoses, maybe then maybe then it would be easier to determine if there is an actual pattern or not, but I can't say right now that there is.
Okay, I think this speaks to the fun of being involved with emerging technologies. They hold out promise, and it's our job to see whether this is in fact hype or whether it's reality. My bias is that it will be, but hopefully next year we can answer your question much more accurately and precisely with some stats behind it to see if there are differences between whether these are phenotype differences within asthma and COPD themselves, or whether there is a cut between the two diagnostic categories is an open question. I don't know if anybody else wants to jump in. If anybody from the Milan group is out there, you guys also have experience with intra-breath, albeit at a different frequency. Good. I see Raffaele lighting up. I hope your microphone's a little bit better because you were slightly on the echoey side.
Okay, so is it working better now?
Yes, go ahead.
I was just mentioning that the difference in the loop that you can observe between the two asthma and COPD patients is probably also due to the kind of selection of patients, because we know that the negative swing of the expiratory reactance is related to the presence of expiratory flow limitation or not. And we have examples of similar loops happening in some asthmatics, despite it is less common. So I think this is identifying, as you were saying, can be a criteria for phenotyping patients, but this is characterizing a specific condition rather than being related to the disease. So this is something that just wanted to.
And Zoli, can I draw you into the conversation as to having any comments, particularly to address Chung Wei's question of mechanics under zero flow conditions?
Thank you for the provocation. I think the sample what Paolo took for an asthma and a COPD patient, it's okay. So the COPD loop exhibits a clear-cut expiratory flow limitation, which does not take is not taken quite similarly with the asthma patients. So that's okay. To go back to the original question, I was rather surprised to find end expiratory and inspiratory reactants as the best performing index in the context of questionnaires, of course. So in contrast to the previous IPF issue which was discussed in Chung Wei's talk, I don't see any physiological link between the MRC or the CAT scores and the end inspiratory reactants. So probably this is phenomenological coincidence, and I wouldn't attribute too much to this high correlation coefficient in this particular case.
Well, if I can jump in once again, Ron, can it be related just to hyperinflation? Like, I have the feeling that any lung disorders will cause some hyperinflations, and that means that you will shift to the right the positions over which you are operating at the portions of the PV loop where the lung is a lot stiffer. So no matter what is your abnormality, as soon as you have like flooding in your lungs or inflammations, like the subjects may tend to hyperinflate, and which will make the lung a little bit stiffer. So when you look at the changes in reactants, it's really at the end of inspirations where the lung is stiffer. So that will be my take on it. But it,
That may be certainly my thinking about it has more been that it's a homogenizing effect, and that there's a huge variability of airway closure and heterogeneity at the end of expiration across this disease category, the COPDers. And by taking the measurement at the top of the tidal volume, so at the end inspiration, you're probably going to normalize a little bit and render the correlations better. In other words, the data is way too noisy in terms of what the oscillation mechanics are at the end of expiration in terms of correlating with the symptom score. That whether that's correct or not, I don't know. That's just a hunch. I can't back that up with any science. I think in the interest of time, I'll give the last word to Thomas Schussler, who's raised his hand, and then we'll move on to Sandeep. So, thank you very much for that. Paolo, amazing job. And Thomas, what are your comments?
I just wanted to, hello everyone, and I just want to quickly comment on the data that you showed comparing pre-COPD to COPD. Because I thought the visual presentation you had there, it might be on the next or after the next slide, shows extremely well how artificial that separation is in a better way than I had certainly seen before. Because I don't know if you can advance the slides here quickly, but the one more, I think. Yes, here. So I mean, the pre-COPD and COPD. The cutoff is very artificial, as Paulo said. And if you then look at the AX data in comparison, you can see that these are really coming from one and the same cohort. And I think this is something that we cannot emphasize often enough.
Yeah, well, this speaks to the concept of lung and transition from health and disease, as per that monograph from the Claude L'Enfant series that our mentors spearheaded, and these concepts they've been grappling with the 1970s, and here we are in the 2020s, still with the same questions to our mind, but with a tool that's now more broadly applicable. Okay, so with that, I'm going to close this discussion down, and welcome to the podium Sandeep Salvi from India. And I have to thank Sandeep for single-handedly educating me, in any case, in terms of biomass COPD. And certainly tell me about your mother's kitchen is part of my routine intake when I see patients coming from elsewhere in the world. But Sandeep is going to tell us about the potential deployment of oscillation mechanics across the Indian subcontinent, which I think will be exciting for many of us. And maybe there are lessons to be learned from elsewhere, but we'll save the comments for afterwards, because that will be my job. So Sandeep, thank you very much for speaking to us, and the podium is yours.
Thank you, Ron, for those kind words of introduction and welcome. I feel very honored and privileged to be a part of this 6th annual Montreal Oscillometry Summer Seminar. My first time that I'm attending this seminar, and I must say that the last one and today, absolutely brilliant data. I got to learn a lot. What I'm going to present over the next 10 minutes is share with you some of the exciting work that we have initiated in India, and to showcase to you what the future holds and how I need help and mentorship from all the experts who are listening to this presentation, because we are very excited to initiate this oscillometry program in India. And there's a lot that we still need to learn, and we will continue to learn. But with your help, I'm sure we can do it in a lot more efficient manner. I was introduced to oscillometry when I was doing my PhD in the UK in Southampton at Professor Stephen Holgate's lab in 2000. So that's 22 years ago. And because I was so fascinated by this novel test that measured lung function just by doing a simple tidal breath, that was one of the first instruments that I bought when I came back to India and started the Chest Research Foundation. So despite the fact that we bought the impulse oscillometer from Jaeger, I had no clue about how to use it, what was the principle behind how it works, and least of all, how to interpret the report. So nonetheless, I started learning about this, and one of the first major advancement that I had was I was invited to write a small review in the Breathe journal, which is a part of the European Respiratory Society, on lung oscillometry. And that gave me an opportunity to do a little more in-depth reading about respiratory oscillometry. And that's where I started understanding some of the basic concepts. Soon after that, we started using this in our research institute. And one of the first studies that we used this was a study that we did quite a few years ago, looking at the phenotypic differences between smoker COPD and the non-smoker COPD. The research question that we asked was, is non-smoker COPD different from smoker COPD? And non-smoker COPD is what I mean by people who are exposed to biomass fuel, by burning wood and animal dung and crop residues at homes as a part of their cooking practices, or people who are exposed to high levels of air pollution, either in the cities and towns or in their occupational workplace. How different is this phenotype of COPD different from the tobacco smoking phenotype? So we had a very large group of people that we studied and did comparisons between healthy subjects, tobacco smoke COPD, and non-smoking COPD. So you can see the three columns over here in the graph, each of these having 3 columns. So you can see the healthy on the left, the smoker COPD or the SCOPD, and the non-smoker COPD. And clearly you see that COPDs are very different from the healthy individuals, but the spirometry was unable to pick up any significant difference between FEV1 and FVC or the FEF 25 to 75 between the smoker and the non-smoker COPD. However, when we use the impulse oscillometer to look at any potential differences, we did identify some potential difference, which was quite significant. So the resistance at 5 Hertz was higher than in the non-smoker COPD compared to the smoker COPD. The area of reactance was also higher, and so was the resonant frequency. Some hint that the non-smoking COPD subjects probably have a greater, smaller airway obstruction than what tobacco smoke COPD subjects have, at least in the Indian population. So this was our first experience of using respiratory oscillometry to understand important research questions for our clinical understanding. And then one of my PhD students who undertook this very challenging task of deriving the reference equation for the impulse oscillometry system for the Indian population. He just completed his PhD about a month ago for this work. And what he did was he put in a lot of hard work going out into the community and randomly selecting individuals, identifying those who are healthy, and then recruiting them into the study. Did spirometry as well as the impulse oscillometry. The age group that he studied was between 20 to 65 years and a very large sample size of 1,200 people. So that included 550 men and close to 650 women. So a lot of hard work went into this dissertation. What we found was something that actually made us feel very disappointed. We looked at the Z5 values versus age, and you can see it's almost a straight line with hardly any correlation. With the R value of 0.2, which means that the R square value is just about 0.5 or 5% of the variability of Z5 is because of age. And more or less the same thing with the R5 and the X5 values. Because we had done the reference equation for spirometry, and we were so happy that gender makes a difference, age makes a difference, height makes a difference, weight has a small contribution, and therefore we had a reference equation which looked quite good. We were very happy, and we were hoping to find the same with the impulse oscillometry system. But there was hardly any association or good association between these indices with age. The only parameter that showed some reasonable association was with height. And that only contributed to less than 10% of the variability associated with Z5. So pretty disappointed that 5 years of hard work was unable to give us a reference equation that was very similar to what we anticipated with spirometry. However, when we compared that with other reference equations derived from other parts of the world, we made two important observations. One is a reasonably flat line across the age range for the resistance and the reactance values, reasonably flat line. And India, the study where we did, clearly has very high R5 values as compared to the Caucasian population. So there was another study from Kolkata which was done, and both these studies from India clearly show that there are significant ethnic differences in the reference values that we obtained compared to the Caucasian, both for R5 as well as for X5. And I was very impressed with what Laura presented. And this is actually what I had anticipated would be the predicted line for the R5 or the R20 values versus the X5 values. On the X-axis is age, and there are two dots over here from early childhood till adolescence, and then the adult age group. And you can see over here how the red line actually goes down from children towards adolescence, and then more or less a flat line during adulthood, just the opposite for X5. And this is just what I anticipated based on the experience that we've had here. And Laura presented exactly the same. So it just gives me more confidence that we are thinking on the similar lines. So we will require an equation, a reference equation in the children age group, because in the initial stages, the resistance values are very high, comes down to adolescent age, and then remains more or less stable. Obviously, there are differences between men and women during the adult age group. So there will be those differences. And I was just doing a simple literature search today morning to see what others have found. And they seem to show more or less the same, exactly what Laura presented in her presentation. And then with the belief that we probably need single cutoff values rather than a predicted equation, we did this very preliminary analysis between healthy subjects and COPD subjects. The numbers are quite discordant. 447 healthy subjects versus 43 COPD. Nonetheless, we just wanted to check if there's a signal that is arising that gives us a strong cutoff value rather than the need to develop a predicted equation. And these are the cutoff values that we obtained with reasonably good sensitivity and specificity. I would say rather good sensitivity and specificity. But these values of R5.56 and Z5 of 0.63 are much, much higher than what has been reported in the Caucasian population. So clearly, I think one of the messages is ethnic differences are very, very strong determinants of what the respiratory oscillometry values are, and we need to find these values for every country separately. More recently, just over the last 1 month, just to show you some of the data that we obtained from a network, and I'll talk about the network in the subsequent slide. Using a device that has been developed in India called as the Antlia device. It's a force oscillation technique that uses an oscillating pump to generate the pressure waves. And using just a small sample size of 93 subjects that included 16 healthy, 33 asthmatics, and 44 COPD subjects, we were able to identify some good, reasonably good signals using this Indian device to show there are differences between healthy versus asthma and COPD for R5, for R5 minus R20, for X5, and for the area of reactance. So it just gives us confidence that this newly introduced Indian device is showing what at least we expect to find in a clinical setting. So these are just very preliminary observations in a small sample size that we just did very recently. Talking about the ARISE network, it's a new initiative that we started last year called as the International Network for Lung Oscillometry Research. I know the term lung oscillometry does not meet approval of many people, but just to make it sound a little more easier for the Indian doctors, rather than calling it respiratory oscillometry, we have called it lung oscillometry. And we're very ambitious that this network that we have initiated would not only include doctors from across India, but we would also expand the network to other neighboring countries as well as other countries who would like to participate in this. The ARISE network is based on 3 platforms, 3 important verticals: research, education, and advocacy, so that all these 3 pillars will help us expand the research and the knowledge dissemination that we need in a country like India, a very large country. So far, we have 23 pulmonologists who have registered with the network across the country, 5 pediatricians, and 1 pulmonologist from Malaysia. So these are very early times, and over the last 6 months, we have generated quite a significant amount of a database from across these different sites. The ARISE network is works on a very simple idea that we are the central coordinating center. We invite doctors who have the oscillometry device to take part in our research and observational research studies and just share with us the data that they generate, ensuring that there is good quality. And together we will start generating new knowledge about the application of oscillometry in our clinical practice. And the last slide is something that is a part of the ARISE network, is a training program that we have initiated called as Omega, or the Oscillometry Training Program for Lung Diseases. An ambitious program has just been launched early this year, and we hope to train more than 500 physicians from across the country face-to-face over the coming 7 months, with some support from the pharma industry and the device that we have been working with it for the last 5 years. Hopefully, once the Omega program becomes more mature, it has more credibility, quality training, we will then expand it to the neighboring countries and hopefully the rest of the world. So these are very exciting times for us in India. We are very novices in this whole space of lung oscillometry or respiratory oscillometry, but we are looking forward to being a part of this very big family that Professor Ron Dandurand has developed and evolved over the last so many years, and hopefully contribute to the knowledge generation from this part of the world. Thank you very much, Ron.
Well, Sandeep, that was wonderful. Thank you very much for a clear presentation. My first comment is it's absolutely breathtaking, the potential there is for advancing oscillation mechanics, caring for our patients with what you've proposed, the infrastructure you're putting up, and also congratulations for reaching out, because I think that we are all stronger together to make sure as we go forward, things are done right. So the first comment is, I think the branding that you're doing is important because there's a certain amount of salesmanship. So well done. But equally, we have to make sure the language is precise. And it's that sweet spot between making it understandable to the clinicians and making sure the engineers and physicists don't cringe because we are misspeaking when it comes to the physics behind the device. And sadly, there are a number of misconceptions out there, which this group is really, I think, at the forefront of correcting. There are many key opinion leaders who misspeak about the concepts and the principles, and it even creeps into the editorials of the highest order journals. So it's a big challenge, but the fact that you're reaching out to us means that we can actually tighten all that up and make sure that we go forward with accurate descriptions.
Absolutely.
I wonder, I'll make a few comments and then I'm going to open up the mic. I wonder the extent of the biomass COPD prevalence in India, and you'll have to educate us on that, because whether it's restricted to the countryside or seen in the cities, I wonder if that's a driver of your higher resistances, lower reactances. Indeed, it was really nice to see those breakpoints, agreeing with Laura's. Device differences also have to be taken into account. As you know, here at the oscillometry unit at McGill, we're the center of the harmonization group where we've documented important differences as impedances, as test loads increase. So we'd expect that in higher impeded people that we would also have discrepancies. So we have to pay attention for that. I'm hoping that you'll be able to donate your new device, so when we go forward with the next round of testing, that your device can be included so we can see how it performs. And then, like I say, I'll just end up by saying it's an inspiration for others, but as they go forward deploying oscillometry, and whether people in other emerging countries, developing countries, I think there's a lot here in the Western world that we could learn from what you're proposing. But I would also ask you to reach out to Hajime Kurosawa in Japan, where I think they've probably got the most effective deployment or penetrance of oscillometry, where Hajime, for a number of reasons unrelated to having more sophisticated GPs in terms of physiology understanding, he's managed to have oscillometry deployed where a significant proportion of the country manages their obstructive lung disease uniquely with oscillometry. So I don't see his name here, but he's somebody definitely you should be connecting with as well. So with that, I hope that a few people will raise their hands and have some more comments and suggestions for Sandeep, and certainly support him as he goes forward with this. And if no one raises their hands, I'll call out people. For example, Zoltan Antosh collaborates with Bangladesh, and so he may have some comments. And I'm wondering if our colleagues in South Africa might have some thoughts to share with you as well.
So thank you, Ron, for those very, very useful and important comments. I fully agree with you that we have to be very correct in the way we disseminate this so-called new knowledge to our doctors. And we need to learn a lot from you, because, as I said, we are novices in this field. We just begun to understand the importance of oscillometry in a clinical practice, and therefore, help from you and from the group would be very, very, very useful for us. So thank you for that. Biomass smoke COPD is a big problem in the rural areas, but even in the urban cities and towns, because India is a pretty polluted country. So there is a very high level of ambient air pollution that people are generally exposed to almost everywhere. So maybe that is the reason why we have such high resistance values across the maybe nutrition contributes to it. Maybe it's exposure to air pollution probably a multiple of factors that make our lungs different from those in the Caucasian population.
Well, I don't see any hands up, but I do see people disappearing. So I'm presuming that people need to come to sign off.
Okay.
This is the first seminar where I think we've actually ended on time. But before we go, I see Chung Wei from Toronto has raised her hand. So Chung Wei, what have you to say?
Well, Sandeep, I want to congratulate you on your initiative and just echoing Ron's comments. But I also want to congratulate you on looking at this at a sort of much wider population level, because as with climate change, pollution is actually a worldwide problem and becoming increasingly more so. And I think that where I see a lot of the value in oscillometry is actually early screening of disease in like the general population, because I really believe that in 10 to 20 years from now, we're going to see this huge burden of lung disease that's going to hit us all globally as a result of climate change, be it pollution or heat or wildfires, which is hitting all across the world and travels, as you know, hundreds of kilometers to affect populations downstream. So just wanted to add my congratulations to Ron's for your initiative.
Thank you so much for those kind words.
Okay, great. Well, everybody, thank you very much for participating this week. Mailer will go out next Monday using the same link. And the recording should be available in the coming days on the website. I do have, okay, they're clapping hands, not comment hands. So thank you very much. I'll close down the meeting now. Stay safe, everybody. Bye.
Thank you. Bye. Bye.
Bye.